Stigma of Mental Health in the United States by Robert Brinkline, Kinsey Plummer, and Mary Quattlebaum. Why did we choose this topic? As future mental health professionals, we believe it is our privilege and right to advocate against negative, preconceived ideas about mental health in our country and in our communities and all around the world. We believe in human dignity that implies that every person should have their rights respected, protected, and fulfilled. It is the job of society to ensure that every person has the opportunity to exercise these rights. We all know someone who is affected by mental illness. It could be our family, our friends, our coworkers. 1 in 5 people in the United States suffer from mental illness. That is 44 million people. Let's normalize mental health.
Are mentally ill people dangerous? This is a question often posed. With concerns to questions as are they dangerous, it's thought to be linked to being incompetent, lack of financial independence, restricted opportunities that may be directed towards coercive care. Corrigan, Shapiro, and Pascalideo would tell us that thoughts of dangers can stem from the casual attributions of mental health. Perry would also say and suggest that these so-called dangers vary in social demographics. So it can be seen where many people believe that those with a mental health disorder are a hazard to our community. The stigma is that these people are a danger to their self or to others, or that they must be criminal or violent. Adults with mental health disorders are often viewed as incompetent people who cannot make decisions, whereas children are often perceived as lazy, violent, or criminal. Next. How do race, ethnicity, age, gender, and education affect people's view of mental health? Younger males aged 15 to 24 often hold a negative belief about mental health care, although there is an increasing positive attitude in seeking help and treatment. Many in the African American population believe that mental health will improve on its own without any care. Those who are educated with degrees approve of and are seeking mental health care at higher rates than individuals who don't hold a degree. These individuals express a greater comfort in their willingness to talk with mental health care professionals. These negative attitudes were typically attached to the perception of people's thoughts that the mental health illnesses were associated to violent behavior. But since 1996, those thoughts have seemed to dissipate and stabilize. With children, they were seen as violent if they had some depression disorders, but male children were seen as more violent than females at the same age. But as a child aged greater than 9 to 14 years of age, they seem less dangerous than the younger children. In addition, children with some form of mental health disorders were seen as lazy or shameful. According to Anglin, 2006, it is believed that adults of different races and cultures had different views in regards that punishment and shame was attached to those with mental health issues, such as white males. But females of Protestant faith and African American adults did not share that belief. Anglin also believed that the income was a form of associated with mental health illness.
Stigmas with drug use can influence medical care. First things first, we need to change our language when referring to individuals with mental health issues. Why? Because it in return can change the way individuals think of themselves so they're more likely to recover, which is the most important thing, right? Language is a key instrument in reinforcing beliefs about a person with substance abuse problems. For example, calling someone a junkie or an addict is not very positive. Using person-first language highlights the person instead of his or her condition. For example, saying addict or junkie is not as good as saying this person has addiction problems. Specifically, healthcare providers have a responsibility to use person-first language because stigmatizing language may influence medical care as well as perceptions that the provider has of the individual with drug dependence. This is not about political correctness.
Stigmas prevent people from seeking care. According to the World Health Organization states that the single most important hurdle in communities is stigmas associated with individuals with mental health disorders. There are two types of stigmas, self-stigma and public stigma. One study looked at 8,285 college students in the United States. Findings indicated that mental health issues amongst early adulthood has a significant impact on perceived self-efficacy, social relationships, academic success, and career success in the future. The study was not able to determine if self-stigma and public stigma have an impact of the utilization of mental health services, and it is clear that more studies need to be done in order to understand how stigma affects the college population and whether or not they seek help. Stigma, mental health literacy, and health outcomes. A different study conducted by Crow, Mullen, and Littlewood analyzes the correlation between self-stigma, mental health literacy, and health outcomes in integrated care. 112 individuals were recruited over a period of time from a waiting room and an integrated care medical center. Participants completed surveys that gathered demographic information and ideology about mental health stigma. Health information for participants was then collected from electronic health records at the medical center. This information was collected over a period of time by students, and this was a monitored research outcome. Notable findings from this study include public stigma and self-stigma prevent many individuals from seeking help. Men hold more stigma towards seeking treatment for a mental health concern compared with women. Women are shown to have more mental health knowledge than men. This also correlates to women having more mental health literacy than men. There's a direct correlation. Continued, additional findings from the 2017 study. Poor health literacy is associated with increased rates of chronic illness, decreased use of health services, increased healthcare costs, and early mortality rates. And just to note, health literacy is a positive understanding of mental health disorders, treatments, and resources that help a person successfully manage a mental illness. Having a mental health issue is a risk factor for developing a chronic health condition and vice versa. Participants who had not received counseling in the past had greater self-seeking stigma compared with those who did receive counseling. The beta weights indicated that for every 1 standard unit increase in self-stigma of seeking help, there was a 0.45 unit decrease in mental health literacy. So basically the correlation is an increase in self-stigma if there is less mental health literacy. How can this information be useful to community mental health providers? Findings suggest that individuals' positive experiences with counseling will positively affect the degree to which they stigmatize having a mental illness and seeking help for a mental health concern. Counselors can use this data to make an educated guess about a client's possible attitude towards treatment. Counselors might consider asking clients whether they have sought mental health treatment in the past. This can be done on intake sessions in their individual early sessions or throughout care. Individuals who have done so may be more open to the counseling process. Conversely, individuals who are seeking a counselor for the first time may have more negative attitudes that can be explored during sessions.
How can this information be used to community mental health care providers? In addition to the public stigmas, negative beliefs and attitudes motivated fear, rejection, avoidance, and discrimination. This resulted in the lack of engagement of quality care, and the outcomes were poor retention and adherence to provider recommendations. This discrimination promoted a reduction in autonomy and self-efficacy and led to segregation. According to Corrigan and Penn, it was believed that this stigma existed in America towards mental health people and was motivated by fear, rejection, and discrimination. It was also believed that this association was linked to care and treatment, creating poor outcomes. This stigma, again, also was related to autonomy, self-efficacy, and segregation. How to integrate Christian scripture and faith into counseling. Many who come to counseling are seeking a meaning in life. They want to be remembered and to be accepted. Religion and spirituality can be helpful when broaching these topics. And these were some common questions that were asked to their healthcare providers. Why is this happening to me? What happens after my death? Will my family survive? Will I be missed? Is there a God, and will he be there for me? And do I have time to finish my work? Some doctors have experienced times during an illness or injury when patients would ask these questions that posed answers that really didn't exist. Yet it's believed that physicians who would go through these times with their patients, talking about these questions, did provide room for some form of healing, whether it was physical, mental, or spiritual. These questions can be like what we just covered, in addition to many more. For many, it's finding a meaning and acceptance in life, which can come in many ways, such as fulfillment of desires through their family and focusing on life accomplishments. There is also leaving a journal for those that might want to be remembered by their loved ones. According to Bachlowski, all the questions that may be asked, there often is no real answer for people, but it seems more than those who are ill have others to share their experiences that they are having, and that healing, even though spiritual, does occur and increases the quality and satisfaction of life. In continuing how this integration in Christian scripture and faith into counseling, true healing comes from this acceptance of the illness and the peace of our life. Some of the beliefs, religious and spiritual, integrated into counseling will include increasing the quality of life, regular spiritual practices, and improved self-control, which also improved coping mechanisms. They found a more spiritual and richer social support and stronger personal values and worldviews. It is easily argued that this does give support to an increase in the quality and satisfaction of life experiences. This is also aids in the client's ability to gain control and how they cope with the pain they may be experiencing. It enhances personal coping skills in all aspects of life, not just with their illness. It is essential to walk with the patient or client about a counselor standpoint on integration. This can increase a client's trust in the healthcare professionals, a client's desire for interaction, and a client's sensitivity towards values. The spiritual coping can impact the client in the following ways: positive outlook towards their illness or despair. It improves the quality of their life with the ability to control the pain and to cope with the possibility of death and illness. It also enhances recovery from surgeries, improves outcomes, and improves issues such as stress, chronic pain, high blood pressure, headaches, and irritable bowel syndrome. Showing clients or patients support in these needs, hopes, and fears, dreams, and their times of despair will create a deeper relationship and a deeper trust between client and counselor. From a personal perspective, these improvements will foster an everlasting endeavor that will benefit the client and the counselor. It can bring the client closer to God or to their spiritual deity, and also allow a greater in-depth in prayer and belief. And to me, from a personal standpoint, that is healing in itself. Aspects of spiritual care. Serving clients with an understanding is essential. This means being attentive and supportive of the client's needs, listening to their hopes, fears, and pains, and dreams of attaining a spiritual history. This also means being attentive and to a client's body, mind, and spirit, incorporating these spiritual practices and making their spiritual leader a part of the treatment team. Public and self-stigmas should not prevent individuals from seeking and getting this compassionate care.
Thank you for listening. These are our references. There are some links here to some resources. We appreciate your time and thank you very much.